Hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to crack one more important topic under respiratory medicine, that is hemoptysis. So in this video we are going to do the clinical blueprint which has a definitive algorithm pathway from etiology to emergency management. Yeah, this is a thing where the patient comes to the casualty, not to the OPD. So you have to diagnose the case in a proper way and manage the patient, otherwise you may lose the patient on the bed. So let's crack it. So the first slide is like the airway versus the blood loss paradox. So we have red flag and its applied aspect. Most commonly the cause of death will be massive hemoptysis is asphyxiation with blood clot, not hemorrhagic shock. So you have to remember death will be done occurred due to asphyxiation with a blood clot. There will be deposition of a clot here and the patient will be unable to breathe. So that's what happens, not in the hemorrhagic shock. Many people think that due to blood loss there will be blood loss which leads to hemorrhagic shock, but that's not the case, but it occurs due to asphyxiation with the blood clot. Remember that the anatomical dead space of the respiratory tract is approximately 150 ml. This is important, you have to remember for your MCQs. A bleed exceeding this volume rapidly fills the airway. Obviously the capacity is 150. If the blood is more than 150, it has to be overfilled. So what is the applied aspect of this slide? Actually the required point, the absolute highest priority in the management is airway maintenance. So when you get a hemoptysis case, you have to first maintain his airway. If airway is maintained, you have to remember that there is something called ABC, airway, breathing and circulation. So in first it stands airway, so you have to maintain the airway maintenance. Then coming to the important point, the dual circulation of the lung. We have systemic circulation, pulmonary circulation. Why we have two types? Just because it has high pressure in the system, whereas pulmonary circulation has low pressure in the system. So the source of systemic circulation will be done by bronchial artery and the source of pulmonary circulation will be done by pulmonary artery. So the most common source of hemoptysis and massive hemoptysis. Remember, hemoptysis is a very small quantity, and even massive means as I said more than 150 ml. So this will be done by your bronchial artery which has high pressure, so it is the main culprit. Then when we see the epidemiological footprint, we see India is most commonly due to tuberculosis, we will see, but in all over the world hemoptysis is seen due to bronchiectasis. So clinical pearl, bronchiectasis is also the single most common cause of massive hemoptysis overall. So India is a small country. I mean, it is not a small country, but comparing to the world globe, it is a small, right? So when worldwide is a bronchiectasis, so we have to take that as a common thing. So overall most common will be your bronchiectasis, but when the question specifies about India, it has to be tuberculosis. Then coming to etiology, we have 5 main causes. We will divide it into 5 main causes: infective, neoplastic, cardiovascular, systemic and traumatic. So in infective, we will see TB, the most common culprit in India. Then we have bacterial, viral and bronchiectasis and bronchitis. Then coming to neoplastic, primary tumors of lung and metastasis. Third we have CVS, cardiac failure, mitral stenosis, pulmonary embolism, pulmonary artery venal malformations. Then we have systemic, coagulopathy, pulmonary renal syndromes. This is pulmonary renal syndrome is an important topic. We'll be covering it soon, so don't forget to watch about it. Then traumatic, direct injury or iatrogenic, which may lead to excessive bleeding from the lungs. Then next slide goes like the pulmonary renal crossover. You have to remember there is something called hemoptysis, there is something called hematuria. Hematuria, hemat is a blood, urea in the urine. So when we combine it, blood in the urine, blood tysis, so in the lungs. So when we see hemoptysis and hematuria in at a time, we call that most commonly as a pulmonary renal syndrome, where we have to make the patient to undergo immediate investigations. The DDs for the list are Goodpasture syndrome, GPS. It is also important. I already covered it under rheumatology. Kindly go and watch rheumatology. Then small vessel vasculitis, it is under rheumatology, and CTDs even that is in under rheumatology. So you have to know that DDs are most commonly in the rheumatology section. Kindly go and watch if you did not watch. Then coming to defining the threshold, massive versus non-massive. Why we call the patient condition is massive or non-massive? We have to know the three criteria. So let's see. First one, if there is a less than 100 ml, then we call it as non-massive. As I said, the dead space will be 150 if that is less than 150, around 100 if that is less than around 100. So we can call it as non-massive. But if it is going above 100 to 150, because anatomical dead space is 150, if it goes above, it will be causing effect to the physiological part. So blood per episode, or it may be more than or 600 ml per day. Primary risk, underlying disease progression, but whereas there will be immediate asphyxiation, as you know, this is the most common cause of death in hemoptysis. Then what is the management you are going to do? It depends on the first you have to classify the patient whether it is massive or non-massive. If you are classifying it under non-massive, then you have to go for diagnostic workup, because the patient is not in that deadly manifestation, so that the patient will collapse on the bed itself. It never happens. So you have to classify him properly, and then you can go for a workup. But whereas in massive, you don't have that much time, you have to manage emergently. So we have to maintain the ABC and stabilize the patient. So in that, first we have to maintain the airway. I hope that is clear. This is important slide. In this hemoptysis, you have to know this part, because you have to manage accordingly by considering the patient whether he is a non-massive or massive. Then coming to the diagnostic workup, we have to do some baseline workup. Like if the patient is not in massive, then we have to go for a workup thing. So first we have to check with a baseline check, and then if we are suspecting, then we have to go for a tier 2 structural. Then if the thing is not appropriate, then we have to go for a particular thing. So specific etiology, if we have any specific doubts, to rule out and save the patient in a further way. So in baseline we have CBC as usual, routines, chest x-ray and sputum examination to rule out TB, king of infective diseases in India. Then coming to structural, CT, we have to check whether the outline is maintained or not, intact or not. Then fiber optic bronchoscopy, it may be flexible or non-flexible. We prefer the flexible part because it goes in anatomically properly. Then in tier 3 we have ECG, 2D, D-dimer, CT, pulmonary angiography, coagulation, profile, urine examination, antibody testing. These are for your rheumatology section. Rheumatology, to rule out any rheumatology, DDs for pulmonary renal syndrome, something like that. Then D-dimer and all, kindly go and watch my pulmonary thromboembolism and pulmonary hypertension videos, which has been already uploaded. You have to go and watch to know more about it. Then we have to manage the patient. If the patient comes in a casualty with a massive hemoptysis, you should be knowing a basic line how to at least stabilize the patient. So let's see how we can stabilize. There may be unstable patient or stable patient. If he is stable, he can bear the pain, so we can go for a definitive investigation, that is CT. Then if there is any problematic, if you feel that we have to intervene, then we have to go with a fiber optic or flexible bronchoscopy. Kindly, if no one saw the fiber optic image, kindly you can go and search in the internet. You will get plenty of images. So I don't want to bulk the slide. Then if there is an unstabilized patient, then you have to do stabilization by maintaining airway, breathing and circulation. there you will be stabilizing the patient. Then we have to go with the rigid bronchoscopy. So if patient is unstable, we can't try with the fiber optic because that will be flexible. We want definitive intervention. We can't play around with the patient who is unstable, so we will prefer the rigid bronchoscopy. Why? Because better suited to deal with the active heavy bleeding and maintain airway. This is the indication for of rigid bronchoscopy over the flexible or fiber optic bronchoscopy. Then persistent hemoptysis is that you have intervened, nothing has been stopped, it is still bleeding. So what you have to do in a further cases? First line, you have to go for a bronchial artery embolization, the most preferred intervention. So if you, the main culprit of the cause is most commonly is bronchial artery. So if you embolize him, most of the cases it will be stabilized. And the second line will be surgical resection of the affected lobe. If the bleed is not stopping even after embolizing the bronchial artery, so then you have to go for a second line treatment, that is your surgical resection of the affected lobe. If the location of the bleed is known, place the patient in the lateral decubitus position with the bleeding side down to prevent the spilling of blood into the compromising healthy lung. Yeah, I know you didn't get it. Simple term. Let's take two lungs. Patient is having blood in the left lung or right lung. Then you have to make the patient to sleep in the same side of lung. Let's take this is affected, so you have to make the patient to sleep this as a lateral decubitus position, so that this healthy lung will be safer and he can breathe. I hope that is clear, no doubt. Then non-massive hemoptysis, as I said, he has time, so you can't play around, but you can take some time to investigate him properly, so that in further ages he never get repeated or recurrence of this condition. So you have to go for chest x-ray, and if there is a normal, then you have to reassure him with the in next slide we'll discuss about it. We have to reassure him and say what are the danger signs. If he undergoes, he has to visit our hospital back. If there is any abnormal chest x-ray, directly go to CT, just followed by fiber optic bronchoscopy. As I said, rigid is preferred only in unstable, because you can't play around with the unstable patients. Then coming to risk stratification, as I said, chest x-ray is normal. Then if there is a low risk or high risk, we have to divide the patient, because contributing factors matters a lot. So if there is low risk profile, just like a no smoker, young patient, then if a single episode is fine, you can just assure him and prescribe some antibiotic, because he will be having some bronchiectasis or bronchiolitis. Then if recurrent, then escalate CT chest. You have to confirm the thing, and we'll make the patient to undergo fiber optic bronchoscopy. If the patient is more than 40 and even he is smoker, then he has to be mandatorily escalate directly to the CT chest and fiber optic bronchoscopy. So the main point, when the patient undergoes CT, he will be undergoing fiber optic bronchoscopy. This is the point you have to remember. The only case where patient doesn't undergo CT and fiber optic bronchoscopy is low risk profile under that single episode, maybe due to some infection, bronchiolitis or bronchiectasis, he may get hemoptysis, which is safer side, nothing to worry. Let's see how we can get a case in MCQs. Let's take 54-year-old female with a known endobronchial carcinoma, left main stem, develops massive hemoptysis, 1 liter of bright red blood in the hospital. So what are the corrective steps you need to take, and red flags you need to avoid? So let's see correct actions. Bronchial artery embolization has to be done, since it is 1 liter. Early bronchoscopy, it has to be done. Placing patient in the lateral decubitus, left side down. Usually what happens, left side down is preferred. Then red flags, do not perform vigorous cuffing maneuvers. If you make the patient to cuff, he may show bronchial ruptures and severity may increase. This exacerbate bleed and increase the risk of asphyxiation, which is deadly complication of hemoptysis. So let's briefly revise it. It's a master blueprint. Before going to the exam, you just watch this slide and you'll be good to go. Airway maintenance is the prime directive. As I said, 150 ml is the dead space of anatomical dead space. Then we have massive and non-massive. In massive we have stable and unstable. In non-massive we have abnormal chest x-ray, normal chest x-ray. So definitive management treatment for persistent bleed will be your bronchial artery embolization. I hope that's clear. This was all about your hemoptysis. Don't forget to subscribe and you can tag me on Instagram. We'll be posting questions or even the important recent updates and all in the Instagram. Kindly go and follow my Instagram handle. So that's all. Don't forget to subscribe. Thank you.